If people have pregnancy while on cenobamate, then those pregnancies are really well studied and see if they have any effects. But right now, it's not recommended. I have to say that we use it in a very special population with very drug resistant, and so this is something that can be limited by other drugs that those patients are already on.
Fellow Homo sapiens, welcome to or welcome back to Epilepsy Sparks Insights. Cenobamate is a relatively new anti-seizure medication which appears to be helping lots of people with refractory focal epilepsy. Today, in part 2 of 2 with neurologist Ricardo Morcos, we learn how cenobamate, as well as preventing seizures in many, may also indirectly positively impact mental health, cognitive function, and even for those who don't get full seizure control, they may actually have a reduction in seizure propagation. Please note that this is not an endorsement of any particular anti-seizure medication, cenobamate or any of the others mentioned, and any questions or ideas from a patient or carer must be brought up with one's neurologist/epileptologist. Please don't forget to share your thoughts on this episode with us in the comments below. Like the episode and do subscribe so that we can educate and empower both more people affected by the epilepsies and indeed more clinicians with patients who have an epilepsy to provide the best care possible.
Hello, I'm Ricardo. I'm an epilepsy fellow at Madrid in Vitas Hospitals. I'm also a neurologist, and I take care of children and adults with epilepsy.
And so one of the most common that I hear of side effects of medication is on somebody's memory. Is it likely, or does it affect memory as well?
Not directly. I mean, there are some studies that try to evaluate this, and I think they give us the confirmation that at least it's not negative. Some of them, as we improve the burden of seizures in this highly refractory patient, some of them even say is good for attention. They improve attention, improve the memory, because at the end you are reducing the interictal activity, and we also see that in the EEG. I think this is something really interesting to see, like how it changed the EEG also. It makes the epilepsy even more focal. Sometimes we doubt where's the seizure onset zone in focal epilepsy, or we have one area in one temporal lobe and in the other more or less at the same time. And sometimes it's so effective in reducing the propagation of the activity that we see, now I see is on the left side, it's not on the right side. So I think the problem is basically, as this kind of population has a lot of medication, it's difficult to reach the dose between 200 and 400 that is the most effective one. So this is the problem that we are seeing in clinical practice, that people, when we try to increase the dose, as people have a lot of other medication, doctors sometimes are not used to manage these drugs, and so they have side effects. And so they stop there and they don't, like, say, squeeze all the efficacy of the drug. So this is something real that happened, especially in secondary hospital or smaller hospital when they use this medication.
So you think clinicians are often just too scared to increase the dosage because it's a larger dose, or because of how it interacts with other medication potentially?
Yeah, especially to be able to increase the dose, you have to reduce other drugs. Usually, there are some patients that have 400 milligrams of cenobamate and are perfectly well, but it's real that if you have 2 or 3 other anti-seizure medication, once you arrive to 200 milligrams, some of them have, and you want to increase because you're seeing efficacy and you're happy, and you say, okay, let's try even to be seizure free. This is something good that we have discussed with patients that we have never discussed before, and say, okay, if in 200 we have 75% of seizure reduction, let's go for seizure freedom. Sometimes we can do it. Sometimes they don't tolerate because they are already another anti-seizure medication. We cannot take it off completely because they have some effect, and so we have to stop there. But it still is a lot of benefits for the patient, because we see reduction in a population that no other medication works. So this is the things that is different in this one. It's not easy to manage everything, and sometimes once you start the drug, you need to see the patient more often. I mean, you cannot put a medication and say, okay, let's see next appointment in 3 months or 6 months. Maybe you need the patient before. So we give the numbers, epilepsy nurse, email. Sometimes we have to trick the system to be able to do this move.
Yeah, no, I get it. And so who would you say that this drug, as we know it at the moment, is definitely not suitable for?
It's, I mean, right now, in terms of regulatory indication, let's say the agency is only for adults and focal epilepsy. But I think we're trying right now, there's a hype, and we're trying in pediatric patients, also in generalized epilepsy, in autoimmune epilepsy, we're doing studies specifically.
Oh, okay.
I think we will have to learn. In some of them, we're seeing the same results as the one we have talked. In others, cenobamate doesn't work because of the mechanism of action.
Yeah.
So we are trying to understand in which type of etiologies of the epilepsy works better. In general, it works really well, but then, of course, there are a lot of different epilepsy and a lot of different patients and etiologies. And the thing is, only if you have a severe damage to your liver, or if you have some cardiac arrhythmias, like a short QT syndrome, something very rare, and it's better if you don't use it. But otherwise, it's good to try. We're trying it on almost every type of epilepsy. We need more information in generalized onset epilepsy, but the thing is that we have already a very effective medication for those epilepsies. So it's not usual that we think about cenobamate in these patients, but for some of them, we will use it probably, and we will see the results.
And so for anybody, I mean, clinicians and patients alike who are, there's been a bit of a understandable, I'm putting this politely, debacle regarding sodium valproate, right? We didn't understand or know, or most of us didn't know about things a good few years ago when the knowledge did exist within some about the side effects. I can imagine that's going to worry some people about a drug relatively new to market. What would you say about that?
With the information that we know, a pregnancy is not recommended while on cenobamate.
Okay.
Yes, this is probably it will have some impact on the fetal health. But of course, we need information once people are exposed and consent to that, of course. But if people have pregnancy while on cenobamate, then those pregnancies are then really well studied and see if they have any effect. But right now, it's not recommended. I have to say that we use it in a very special population with very drug resistant, and so this is something that can be limited by other drugs that those patients are already on. There are a few medications that are safe, relatively safe during pregnancy, but the majority of them are not 100% safe. So cenobamate, I will say, in this area is on the bad side, let's say on the negative side. Yeah.
Oh, we should be careful not to go too crazy with the worry of that. We were talking about this before, like not everybody wants to have children anyway, right? So say you're of breeding age and you have refractory epilepsy until you come across this drug, but it's biologically a woman. Would you, I mean, I'm thinking I don't want clinicians to be nervous to suggest a potentially effective drug to a biological female just because they're worried that she will breed, because I know this has happened a bit with sodium valproate.
I think you have to discuss it with the patient. I think quality of life, in life in general, you have to make decisions. And I think patients have to talk about it and say, okay, I prefer to have an uncontrolled epilepsy with this drug that are safe during pregnancy. I have to say that if you have an uncontrolled epilepsy, having a pregnancy increase the risk of malformation if your epilepsy is not well controlled. So anyway, I think it's something difficult. But I think it's on the patient. I think we have to offer these tools. You can give them the medication, control the epilepsy, and then once it's controlled, you can think about, okay, maybe we can take this medication off and see or reduce the dose at the minimum level, considering the risk or looking for another alternatives about pregnancy. Right now in this century, we have alternatives, and I think we can discuss with this kind of difficult to treat patients.
So it's not one size fits all, and it shouldn't be ruled out just because somebody may breed. It's a kind of just treating each person with epilepsy as an individual, and this drug may or may not be suitable for them.
Priorities, but we have to ask them and consider. I think this is the medicine in this century,
right?
Where we work together with the patients, we explain all the possibilities, and we prioritize them in terms of, this is the most important thing in my life. I want to be a mother. Okay, let's try with all the medication that are safe, and then if it doesn't work, okay, then let's try another thing. Or maybe for most of the people, like right now, it is say, okay, now I'm not considering right now, let's control this, and then I will think about it. I think the majority of patients in general tells you that. I mean, if you consider whole population, all ages, and both sexes.
It's about compromises, I guess, one has to make, and I guess like personalized medicine and just looking at the whole picture. And I mean, I can say as a person with epilepsy, if I speak to, and we were talking again about this before, I had a great chat with my GP this morning. I loved her. Oh my goodness. But how they explain things to you. You can present your challenges that you, as a clinician, you'll understand things from a certain perspective, but it's important to understand it from our perspective. And then if we know that we're listened to and the decisions, it's a joint decision that is made, assuming that a patient can do that, you leave with a smile on your face rather than oh my God, I've lost something.
At the end, we're talking about the life of the patient, and we have a small perspective. We have some data, and we want to help patient to take the best decisions. Of course, our responsibility is to inform, explain, and sometimes even motivate. Let's say we have to do this sometimes with Cenobamate, because many people with epilepsy, and I think this is an important issue also, have lost faith in drugs. And with a lot of reason, because the numbers say so. Like the probability of seizure freedom or a real impact in the epilepsy after trying 4 medication is really low. So we understand you. But sometimes what happened to us is like when we propose, we're very happy with these new drugs, and I say, okay, let's try something new. You will have a real opportunity to change the way that your epilepsy, to change the seizure frequency or change life. And so say, okay, no, I don't believe in drugs anymore. I've tried a lot of medication. No one works. And we usually say, no, but this is different. And we show them the data. And that's why I think it's important to have this kind of conversation that can reach patients, and so they can believe their doctors, their medical team, when they propose this, because I think it's worth it. And at the end, the majority of them say, okay, you were right. It was worth trying, even if they are not seizure free, because 80% won't be seizure free, but they, like 6 out of 10 has a really good result with drugs. So it's something worth trying.
Thank you very much to Ricardo for sharing with us in part 2 of 2 such valuable insight into Cenobamate. If you're interested in learning more, please make sure that you do check out the paper Spanish Consensus on the Management of Concomitant Anti-Seizure Medications when using Cenobamate in adults with drug-resistant focal seizures, the link to which you can find in the text below. Check out more about Ricardo and his work on the website torierobinson.com, where you can also access the podcast, the video, and the transcription of this episode. And if you haven't already, don't forget to like, comment, and subscribe to the channel. Share this episode with your friends, colleagues, family members, and see you next week.